Good morning. My name is Julie Burns, and I'm the president and CEO of RIZE Massachusetts Foundation, and I want to welcome you to today's summit, Person-Centered Care in Treatment and Recovery for People with Substance Use Disorders. Before we get started, just a few announcements. All participants will be on mute throughout the program. Questions can be asked by using the chat option on the toolbar, and please feel free to send your questions throughout. The webinar is being recorded and will be posted on our website. We are also live tweeting the event. Please follow us on Twitter and join the conversation. Our handles are @RizeMass and @C4Innovates, and we'll be using the hashtags person-centered care and hashtag #0stigma0deaths. Finally, you'll receive a survey at the conclusion of today's event, and I hope you'll take a minute to fill it out to help us plan future programs. I'm so pleased to see that we have attendees from all over the country. I think I counted 14 different states on the attendee list. So a bit of background for those of you new to RIZE. Launched in 2017, RIZE is an independent nonprofit foundation created to end the overdose epidemic. We're made up of a constantly growing group of providers, payers, unions, advocates, and people with lived experience who are equity-minded, entrepreneurial, collaborative, and dogged in pursuit of our mission. We believe in shared responsibility and a sense of urgency. Addressing the overdose crisis can't wait, and it's going to take all of us to make a difference. One of our strategies at RIZE is to serve as a neutral convener, bring people together, support exploration, share learnings, enable change, and that is our goal for today. An example of this work is our Together in Recovery initiative. Together in Recovery is designed to foster an accessible, integrated treatment and recovery network in Massachusetts that champions evidence-based approaches, supports multiple pathways to recovery, and puts people in charge of decisions about their treatment. We are honored to be partnering with C4 Innovations for today's summit. They've been our main collaborator in Together in Recovery since it was launched in 2019. Can we go to the overall goals slide, please? Thanks. Today's convening is about sharing experiences, ideas, and best practices to create a more inclusive, person-powered treatment environment for those with addiction. With that in mind, here are today's goals for our summit. Gather input and discuss strategies to implement person-centered care across treatment systems and settings, and identify action steps to implement person-centered care in your own organization and practice. Next slide, please. We're hoping to guide today's discussion with some stated objectives to help us reach our goals. Specifically, we'd like to learn about the elements of person-centered care, understand the benefits for people receiving services and providers. For our healthcare providers, we want you to be able to assess your own practice and appraise your organization's alignment with person-centered care. We're also going to hear examples about how to engage people in shared decision-making and enhance our understanding of what person-centered care looks like in practice. And finally, we plan to produce some action steps to advance the implementation of person-centered care and addiction services. Next slide, please. Given our objectives and goals, here's how we'll spend our time together today. We'll begin by bringing person-centered care to life with some huge rock stars in the field of addiction medicine and peer supports. Dr. Sarah Wakeman will moderate a discussion with subject matter experts Mr. Mark Mohammed and Dr. Nzinga Harrison. Then Dr. Cheryl Gagne will lead an interactive virtual discussion of person-centered care practices so we can learn from each other about how to build on this work. Lastly, Daryl McGraw and Livia Davis will close out our program with a one-on-one session call to action. That's one thing you can do and one thing your organization can do. So keep that in mind throughout the event. Next slide, please. We're eager to get underway. So with that, I'd like to introduce the participants in our fireside chat, bringing PCC to life. First, we are so honored to have Dr. Nzinga Harrison with us. She's the co-founder and chief medical officer of Eleanor Health. With more than 15 years experience practicing medicine, she's a double board certified physician with specialties in adult psychiatry and addiction medicine. Dr. Harrison did her undergraduate training at Howard University, medical school at the University of Pennsylvania, and her residency at Emory University. She spent her career as a physician treating individuals from marginalized communities with substance use and other psychiatric disorders. As a physician executive, Dr. Harrison has served in senior vice president and chief medical officer roles and is committed to improving systems-based delivery of psychiatric and substance use treatment. She is a vocal advocate for stigma reduction and is passionate about the importance of whole person care. We also have Mr. Mark Muhammad with us. He is a certified recovery coach and recovery coach supervisor for Choice Recovery Coaching at the Mass Organization for Addiction Recovery. As an individual in long-term recovery, Mark uses his own experiences to relate to the individuals he works with while supporting all pathways to recovery. Mr. Muhammad earned a certificate in drug and alcohol counseling from Cambridge College, a bachelor's in psychology from Boston University, and has been a recovery coach trainer for the Massachusetts Bureau of Substance Addiction Services since 2015. And I'm excited to introduce Dr. Sarah Wakeman, our moderator for today's discussion. Dr. Wakeman is medical director for the Massachusetts General Brigham Substance Use Disorder Initiative, program director for their Addiction Medicine Fellowship, and assistant professor of medicine at Harvard Medical School. She is also the medical director of the MGH Addiction Consult Team, the co-chair of the MGH Opioid Task Force. She is a fellow of the American Board of Addiction Medicine and board certified in addiction medicine by the American Board of Preventive Medicine. And nationally, she is the chair of the American Society of Addiction Medicine Drug Court Task Force and also serves on their ethics committee. But most important, Sarah has played a central role in the creation and formation of RIZE and is a very valued member of our program strategy committee. So welcome to all of you and thank you for joining us today. I know I'm looking forward to this discussion, and with that, Dr. Wakeman, I will hand over the reins for you to begin.
Fabulous. Thanks so much for that introduction, Julie, and thank you everyone for joining. I'm delighted to be here today and great to look across and see many familiar names and faces and some new friends joining us, so thanks for being here. And we're excited today to have a fireside chat talking about patient-centered care, and want to thank RIZE for hosting this amazing event and inviting us to participate. As Julie mentioned, my name is Sarah Wakeman. I'm an addiction medicine physician and medical director for substance use disorder at Mass General Brigham. I've had the great pleasure of working with Julie and RIZE since the very start, and I'm so proud and impressed by the work they continue to do. This morning, I'm joined by two amazing colleagues and friends, Dr. Nzinga Harrison and Mr. Mark Muhammad, and we'll be talking about what is person-centered care for people with substance use disorder. But what we'll really be focusing on is what is at the core theme of all of our work, connection and humanity. As I met with Dr. Harrison and Mr. Muhammad to plan for this session, the theme that really came up at the core of both how we do this well and also what makes it so rewarding was the notion of connection, humanity, and dignity being the root of everything that we do. Unfortunately, the experience of people who use drugs and those with substance use disorder, particularly in healthcare settings or in society generally, has not always been one of feeling connection when coming into contact with systems, even those of supposed care. Stigma towards people with substance use disorder has been enshrined historically through segregation within the healthcare system, where addiction care is carved out from the rest of a person's medical care, where people can be denied certain medical interventions or access to medical or addiction treatment facilities based on their substance use disorder or the types of treatment they're engaged in, or even denied employment or safe housing. And where approaches to patient care for substance use disorder can look vastly different than how we would think about treating other health conditions like diabetes or HIV or depression. In addition, our society's drug policy and approach towards people who use drugs has been fueled by racism from the very beginning. When Black, Latinx, or Native American communities have been impacted by substance use or overdose crises, the response has been one of criminalization and punishment and family separation. The growing awareness now of the need for a public health approach towards the current overdose crisis has itself been shaped by racism. The shift from a criminal legal approach to a health approach has largely been driven by the perception that the current overdose crisis is impacting white people. Despite the rhetoric that we can't, quote, arrest our way out of the overdose crisis, which we hear all the time, we continue to see our correctional facilities filled with Black and Latinx individuals incarcerated on drug-related charges, and Black children overrepresented in the foster care system at 2 to 3 times the rate of white children, predominantly due to allegations of parental substance use. When people who use drugs and those with substance use disorder have intersected with the healthcare system or tried to access help, they may have encountered stigma, unconscious bias, outright discrimination, or racism. A 2016 qualitative study described the experiences of people who use drugs who come into the hospital. Common themes included the lack of compassion shown by providers, a lack of attention to the subjective needs of patients who use drugs. And one participant said, you could just show a little more compassion and gentleness. Understand that good people also use drugs. Maybe don't deny them proper medications for pain or withdrawal just because of their addiction. Give them a chance to heal and to get better. Thankfully, we today are here with a shared mission of the importance of committing to recreating systems of care for substance use disorder to ensure that people have access to effective treatment, that it's accessible, available, and centered around the needs and goals of the human beings who are impacted. There's been amazing progress and so much to be proud of. And at the same time, this is a long-term journey, and there's always continued work that we can and must do to improve the care of people who are suffering. Today, we'll explore what is person-centered care, what is a compassionate and effective approach to caring for and partnering with people with substance use disorder, and what does that look like from two experts who I'm so thrilled to be partnering with. I could be more honored to be joined this morning by these two leaders and human beings who are here to share their wisdom and lived experience. Through listening to their stories and experiences, I hope you leave feeling inspired, ready, and called to action to continue to work with us on bettering care for people with substance use disorder. So with that, I'm going to turn first to Dr. Harrison and then to Mr. Mohammed to share a little bit about themselves, who they are and what they do, and then we'll move into some of our discussion questions. So Dr. Harrison, I'll turn it to you.
Thank you, Sarah. So glad to be here this morning and really want to emphasize what you said about compassion and connection. My personal philosophy, as well as our foundational belief at Eleanor Health, is that compassion and connection create health, and marginalization, oppression, and disconnection create illness. And so we have to be undermining marginalization, oppression, discrimination, and maximizing compassion and connection if we want to help people get to their life meaning and sense of purpose. So who I am, I'm a mom, 2 teenage boys, 14 and 16, wife. I live in the Atlanta area. As was said during the introduction, double board certified physician, psychiatry, and addiction medicine. Have spent my career really trying to raise my voice on behalf of those who have been invisibilized by so many systems, including people who use drugs, especially those who are actively using drugs and not yet in recovery, people with serious persistent mental illnesses, complex physical needs, and social drivers of health needs. So really happy to be here to have this conversation. Thank you.
Thank you, Dr. Harrison. Mr. Mohammed, I'll turn it to you.
Thank you. First of all, I'd like to thank RIZE for even inviting me and having me here with such a group of esteemed people. You know, it's interesting that we're speaking about person-centered care. And I guess I sit in the seat of someone who just uses his own personal experience to be able to meet people where they're at. Me, like Dr. Zinga, I'm a married man with 2 children, but I don't have boys, Dr. Zinga. I have girls. So I was always taught girls are blessings because they're helping. So as you get old, it would be the girls that would be there to help and assist. But with that being said, I just look forward to give what I have, what I'm able to give, and just learn whatever else that is presented at this particular workshop so I can take it back and share it with others in the field that I work in. Thank you.
Thank you. So with that, I'm going to turn to a few discussion questions to get our chat going, and then we really want to have participation from the audience. So feel free to chat in questions, and after we finish with some of our kind of discussion, I'll be turning to the chat and we'll filter through questions from all of you. So share your thoughts, questions, comments, whatever you want to be a part of this conversation as we go. So Dr. Harrison, I'll start with you. I've had the absolute joy of listening to you speak in the past and heard you always center the need and framework for a holistic, person-centered approach to care. In particular, I recently got to hear a new term, which I adored, that you used, where you reframed the sort of traditional biopsychosocial model of health to really broaden it and use the term biopsychosociocultural political model of health. I love that broader vision. I wonder if you could talk more about how culture and politics really play into thinking about true person-centered care.
Thank you so much for raising this. So I always make the joke that it's now super califragilisticexpialidocious with all of these extra syllables, but in our social services and medical training, we're trained on this biopsychosocial concept of illness and health that says every illness has biological inputs, psychological inputs, social inputs, and we've narrowly thought about those social inputs as social determinants of health: housing, finances, relationships and connecting, safety. But what we've not been introducing in the conversation is the impact that cultural and socio-political factors have on health, to those comments that you made in the opening comments. And so as I've been trying to spread that biopsychosocial cultural political framework, cultural political is race, ethnicity, the part of the country you were raised in, the family you were raised in, and the values and self-esteem and life meaning and purpose messages that you were, all of us, programmed with, depending on those early experiences. And then, of course, politically, like you said, our healthcare system specifically, but all of our systems have been structured to marginalize and oppress certain groups, certainly Black race, non-white race, LGBTQ, in communities that are rural, in communities with lower socioeconomic resources, people who are using drugs, people with other mental health conditions. And so if we can take the approach that we've begun to understand that the rule in people who use drugs is an exposure to complex psychological trauma. And so we hold ourselves to the responsibility to build trauma-informed systems. Then we should also be understanding that the rule, not the exception, is that your identity informs the experiences that you have, inform the marginalization you face, the discrimination you face, the oppression you face, the racism you face, and that those increase risk to developing all illnesses, substance use disorders included, erect barriers to getting access to treatment for those illnesses, and increase the chance that you will receive disparate care once you've accessed those services. So if we truly want to be practicing person-centered care, that centering also has to be on not just who the person is, but what the cultural political experiences have been that are affecting that person's health.
Absolutely. Yeah, couldn't agree more. Taking that and turning to you, Mr. Mohammed, I'd love to hear your perspective on person-centered care, what that means, and building on what Dr. Harrison mentioned about the importance of each person's culture and their community. How do you approach each unique individual to listen and explore what their context and their goals are?
Very interesting. I too was raised in the South, and it gave me a whole total different perspective of being disenfranchised and seeing how people view people. But then when you come up into the North, you see it on a larger scale. And then to top that off with leaving school and then not knowing how to engage with people after not being successful in the world of sports, which I was in playing football, I fell into the path of addiction and using drugs, but was able, through the grace of God, of course, to be able to come forth and come up out of that. So when I look at person-centered care and dealing with people from the goals and the context that you was talking about, like I said earlier, it's bringing myself to the table, but also paying attention to that person. Even though each person may have different goals in their context or their surroundings and environments or circumstances may be different, those whom I deal with and those who I'm engaging with, they all have one thing in common, and that is that they're suffering from an addiction that may be a disease or behavior, depending on how you want to view it, and they want to have help. They want to be able to remove the obstacles and barriers that may be placed in their way. And that's where I sit. It's just to be there for them, be present. So often people who are disenfranchised, nobody listens. So there's a book by Dr. Bessel van der Klerk. I just like the title. Even though there's a lot of great material in there, the body keeps the score. So when I think of the biopsychosocial or BPS, I can't pronounce all that other stuff you said, Dr. Sinka. So we might give that a whole new language. I think about that. The body keeps the score. So when I sit down I have to really not just listen to them, but also watch their movements of their body, and understanding them. And then be able just to come to the core of what may be troubling them by asking them the questions, listening to it, and then helping them see the issues that they may have in their life, and then work with them to help themselves to reach their goals. But I'm glad she brought that up about that aspect about culture. We talk about being cultural competent. Some people say they rather use the word cultural humility, either or, whatever allows you to be able to engage people, to understand people. But at the core, we must be very conscious and aware of people's differences. We are all humans, and that does not mean to not look at the racial issues that happen in this country, the people not understanding, the people from the LGBTQ community and others who just may not fit into what the norm, so-called norm, may be in the society. So I'm glad she brought that up about the BPS. And I think that needs to be more, where people be more person-centered, looking at the needs of the person, but most important, to listen to that person in order to help them.
Yeah, listening at the core, getting back to that connection piece. I think that's a perfect segue, Dr. Harrison, back to you to think about sort of moving from the macro down to what you do in the clinical work of how you sort of take this person-centered care approach and really apply it in clinical practice and meeting a person where they are.
It's exactly what Mr. Mark Muhammad said, which is listening. And so what we really try to focus on is building the capacity of our team members at Eleanor Health to have these conversations, to recognize. So Mr. Mark said, being acutely aware of that person's life and experience and identity being different from yours, and being able to have the conversation around that. We've really been taught in this country that those conversations are dangerous. We've been taught in healthcare that those conversations are not necessary, right? Like, I just need to know, is your urine drug screen positive or negative? And that'll give me the information I need to take care of you. When really, I would have never known Mr. Mark Muhammad was an athlete, and that was a formative part of his identity. And a formative part that had a lot to do with the development of the illness of substance use disorder. Growing up in the South, like, you don't think of being an athlete as cultural political. It is, it comes with a set of experiences. Growing up in the South, moving to the North, that disconnect. I grew up in the Midwest. I went to school in the Northeast, and I was, in the street, like, hello, how are you? And people were like, yeah, weirdo, right? Like, these cultural differences lead to experiences. And so it is, how do we take the concept that whatever I think I know about this person, my eyes see you, my brain develops a concept of you that is only 100% rooted in my own previous experiences of people like you, however my brain is defining that. And so how do we teach our workforce and our support systems and loved ones to not sit in that concept, but rather drop into that listening that Mr. Mark talked about, and say, these are some of the experiences we know people typically have. Have you had these? Has this affected you? But help me get to know you. Even before I need to know your illness, I need to know you so we can make that connection, so we can nest in trust and relationship. And then it makes all of those more difficult conversations safer. And that connection then makes the treatment more effective.
And Dr. Harrison, just taking that one step deeper, because you talked at the beginning about one of your personal passions is, of course, substance use disorder broadly, but in particular, working with people who are actively using drugs. Mm-hmm. And I wonder how that translates even a step further into sort of people who are still active, who maybe have been sometimes left behind a system that expects people to come in sort of ready, and if not, can blame them.
Absolutely. So I'll start with a quote that I absolutely love by Monique Tula, Executive Director, Harm Reduction Coalition. And she says, harm reduction is the practice of unconditional love for people who use drugs. I absolutely love this quote because even though you're using drugs, we don't want you to die. We don't want you to be sick. We don't want you to be disconnected. There's a spoken word artist named Joseph Green that I recently was connected to, and he has a poem called St. Jude, and it's for those who have ever believed they were a lost cause. We don't ever want anyone to believe they're a lost cause. And so the practice of harm reduction, and I would like everyone who is in any treatment setting, if you are not practicing harm reduction, that doesn't mean you have to give clean needles. Harm reduction is the same as a person with a blood sugar of 800. We will treat you, and if we get your blood sugar to 400, we have reduced your harm. It's 400 the goal for us? No. Would we love complete abstinence because that's the safest? Yes, but are we going to disconnect you and kick you out because you're not at complete abstinence? No, because that's how people die. And so it is bringing that concept that even while actively using, even while cancer is not in remission, even while blood sugar is not controlled, even while blood pressure is still high, that's when actually folks need the most arms and the most treatment and the most involvement, and you just keep trying. If you keep that thread of connection and relationship and trust, you just keep trying, you do better for more people than having to be ready for chemo before we'll treat your cancer.
Yep, love it. Or hitting bottom before you get diabetes care. Yeah,
right? We're not treating that
Harrison.
diabetes until you're in a coma.
Yeah.
We wouldn't accept that for any other condition.
Love it. Mr. Muhammad, I think turning that to you, the notion of unconditional love being at the root of so much of what we do is beautiful. I think in some ways we could say that about person-centered care too. I wonder if you could share any examples of when you've seen that go well for either a participant or someone that you've partnered with, or times you've seen it go poorly, but in terms of learning for the group about what this actually looks like in real life.
When does it go poorly? When does it go good? Well, I can speak from my own personal experience that I would like to think that I definitely utilize person-centered care because I bring myself in that. And to do that, I also know that as long as I continue to keep developing as a coach to learn more about myself and be present, then I can be good at what I'm doing to help somebody. So when I'm supervising people, one of the first things I always want them to do is don't become robotic. You know, we go to trainings, we learn things, learn the principles, but bring yourself. Because there's an aspect of yourself that I can't duplicate, I can't replicate, but you can. But at the core of that, and the key thing is making connection, because that's what's going to make you genuine, which is the aspect of person care, to really make a connection with that person. And people know. They know when you actually care, and they know when you don't. Oftentimes when we deal with people, especially in the recovery coach field, we're with people, we're in the trenches. We're the ones down in the hole and the war's going on, which we all know that war is addiction. And so we jump down in that hole with them as recovery coaches to let them know that they don't have to fight alone. They don't have to be alone. They don't even have to suffer in silence. They now have somebody there for them. So far as being, I don't like to look at, even though it may be that, when I'm working with people, because I know we're all people striving to better our art and learn more about the science of recovery. So it's just working with people. I don't like to look at the bad. You know, if I'm that person with you supervising, I want you to bring the best that you can be. Let's work on that. Let's focus on that. And then at the end of the day, because I believe God gives everybody something inside them. And most people, when you went through addiction, everybody wants to help most time when they come out. But then there's those who are really sincere. And now all we got to do is just refine our craft in order to be able to help somebody. And so that's where I'm at. So I've tried to focus on the good notes, not so much on the bad, and just work on that area, because it's not like I'm perfect. It's not like I'm perfect, but I may know a thing or two. And that thing or two, I know I pass it on to help somebody else that I'm working with.
Yeah, I love that. Listening, partnership, love, and emphasizing strengths and the positive are a wonderful way to think of it. Dr. Harrison, I'm going to turn back to you based on what you're talking about at the beginning about sort of the political and the cultural on that great social media platform, Twitter, where we met and which I adore. I myself have been accused of not being apolitical, that doctors should be quote unquote apolitical, which I've always thought it's a bit of a privilege to even be able to think of things as apolitical, but I wonder what you would say to that, of the notion of what is doctors' role in advocacy, in dismantling racism, and in politics. How do we think about our role sort of as clinicians, but much broader than that, about some of these challenges going on across our society?
Yeah, so we learned in medical school about 4 basic medical ethical principles. And the one everyone always hears about is non-malfeasance or non-maleficence, depending on what part of the country you're from, which is first, do no harm. But there's also beneficence. And the ethical principle of beneficence requires us as physicians to advocate against those things that harm the health of our patients and to advocate for those things that improve the health of our patients. So the very basic, I don't think anyone can say that our political systems don't affect the health of the people that we're caring for. Some affect positively, some affect negatively. I don't believe there's any that is neutral, because every part of our lives is informing our health, and all of our political systems are somehow interacting with our lives. And so if we just look at that basic medical ethical principle of beneficence, that holds physicians to raising our voices in advocacy. We know that housing affects health. We know that education affects health. We know that discrimination, marginalization, oppression affect health. We know that disconnects education, schooling, every legal, financial, wealth, like criminal justice, all of these systems where we have so much disparity are driving illness. And so if we know they're driving illness, beneficence says it's our responsibility to advocate for the continuous improvement of those systems.
Amazing. Love it. Thank you. So we're going to get ready to turn to the audience. I already see some questions, so please keep chatting them in. As people sort of put their questions in the chat and think about how they want to join us in this conversation. Mr. Muhammad, I'll turn to you first and just say, what is sort of one last take-home point you want to make sure the audience leaves with when they think about the term, what person-centered care is?
I think it was Lao Tzu who said, "He who knows others is wise, he who knows himself is enlightened." So one thing I would say is to leave them with is that being person-centered, especially as a recovery coach, be able to bring yourself and know yourself in order to work with others.
Love it. Perfect. And Dr. Harrison?
I want to dovetail on that because we're really taught as healthcare professionals to have these boundaries.
Yes. Mm-hmm.
And what they actually do is erect barriers to genuinely being able to be with the people that we're serving. And so I want to echo what Mr. Mark Muhammad said, which is, it is okay, not even it's okay, you have to be able to bring your full self to the care that you're giving to people. You have to be able to share of yourself to make that true connection and genuine connection to make a difference.
Love that. So now we're going to start incorporating all of you into the conversation, into our fireside chat. So I'm going to start taking questions that I see, but please share questions or comments or anything you want to bring to the conversation, or even if you have points about person-centered care that you want to leave us all with, we would love to hear that. So one question that came through in the chat is that there's a longstanding practice of not helping people to access addiction services, because if they don't do, quote, all that work to find a program that matches their needs on their own, then they're not, quote unquote, ready for recovery. Can you tell us, each of us, your thoughts on that paradigm? So whoever wants to start, take it away.
Can I start, Mr. Mark Muhammad?
Absolutely. I'm going to dove off for you.
Okay. Capital, bold, underscore, italics, 5 exclamation points, trash. That's how I feel about it. That practice is trash. I say this vehemently and passionately because think about the person who has just been diagnosed with cancer and the supports that we erect around that person to help them navigate this web myriad impossible to navigate even for people who work in a healthcare system that we have. That is asking people to die. So when they are struggling the most, when their illness symptoms are the most severe, when we know we're dealing with the illness that affects the brain, which is required to do all of that work of finding the right program, when we know the definition of the right program is not even clear to people, when we know there's so much risk for abuse for this vulnerable population on the internet, which is where people have to go, when we know people don't even have access to the internet, like I could go down so many reasons why I put bold underscore exclamation points and italics and capitals on the word trash. It comes down to you don't ask people who are suffering to do all the work. You help. And so we think it's our responsibility to find those folks and put our arms around them and say, you may not have even known we existed. At Eleanor Health, we have a whole proactive outreach and engagement function where we're calling people. You may not have even known we existed, but we are here to help you and put our arms around you. That's what people need when they're suffering. I don't know if you want to dovetail off of that, Mark.
Oh, no, ma'am. I love what she just said. And the reason why is because I believe it's the William White who's like the guru when it comes to addiction and recovery. And one of his quotes is that you're in recovery when you say you are. Now, that's very hard for some people to work, to wrap their mind around it. And I will be honest, I couldn't wrap my mind around it at first either till I began to understand that use of language in being a recovery coach. Being a recovery coach, it's not up to what I think, what that individual's plan should be or where they're at. Being a recovery coach is listening to them and helping them find their way in their recovery, wherever that may be. So Dr. Zinga spoke about harm reduction. You know, you may have to be with somebody who is using medicated assisted treatment, which at first years ago, I did not accept it because I did not understand it. Even though I had little schooling to get some training in it, I didn't really understand it. But at the end of the day, if you can save somebody's life today, it gives you another day to work with them so that hopefully they won't continue to be on that path of medicated assisted treatment. You know, and that's the key, needle exchange. You know, when I look at it, why would somebody who is addicted to using intravenous use, drug use, want a clean needle, if I may use that term? Why would they want that? There must be something in them, their God consciousness in them that's saying, I don't want to die, I want to live, but something keeps pulling me in the opposite direction. And that's why I come in as a recovery coach, to ask them questions, to get them to understand why these things actually going on in your mind, but then understand it and not to the point where I'm not condemning them, but I'm going to help them, because oftentimes we find that it's the recovery. They know, they have the answers. It's asking them the right questions, because we're buried in so much pain over the years of abusing ourselves that we don't even hear ourselves. So I become that voice within their head until they can begin to hear that voice within themselves. So I love what you said, Dr. Zinga.
I love what you both said, and the chat is full of a lot of celebration of all the words you guys are sharing. And I think that notion again of listening, Mr. Muhammad, and also really the idea of self-defined recovery and celebrating any positive change, you know, that again gets back to this unconditional love and partnership with the people that we're partnering with and serving, which I think is at the core of both recovery work and harm reduction, which sometimes are made to seem as if they're diametrically opposed when really it's the same path. That's all a part of the journey. So thank you for those pieces. Another question that came through is, how do you keep your professional boundaries while still giving your clients all of you?
Say that again.
How do you keep your professional boundaries while still giving your clients, quote, all of you?
Interesting. I'm thinking of that song. Who is it? Is it John Legend?
Oh, yep.
Give all of me. You know, you cannot help someone if you don't give all of you. I'll give you an example. If I see somebody, an old lady, and she trips and she falls on the street, I'm going to show her compassion and help that old lady up. Now, are there boundaries for me not to touch that old lady and help her out when I see her in need? So the beauty about what I love about recovery coaches, there are certain boundaries we don't have where we're allowed to engage them a little bit more. But then there's that human part. As a recovery coach, that we should know there are things in certain organizations they implement so that you have a thorough understanding of it. But like I said before, I don't believe in being a robot. I believe in bringing yourself and using common sense. But when common sense don't work, you do have to have a protocol in place just in case. But there are certain parts as a human being you know not to do when you engage another human being to help them. You just met that person on the street and you've seen something happen to them. And that's the part I'm talking about. Just knowing what's ethical, what's morally right and what's not. What's right and what's not.
Yep.
So that's why I stand that on that.
I love that. And I think one way to approach that question is to think about what is the purpose of the boundary that you're setting. So I'm trained as a psychiatrist, and we are trained in like some super duper boundaries that I am in public on record saying I do not respect the boundaries that I was trained with as a psychiatrist, right? Keep affect neutral, which is very injurious to a person who is sitting there crying and traumatized, and you keep affect neutral. That's injurious. Don't hug people. I have somebody sitting in front of me who just lost a loved one and I can't hug them. Not doing it. Don't eat during your visits. I'm a human and I didn't take lunch. And if I pull out a snack, I'm going to offer the patient who's in the office with me some of it. You know what I mean? Like, just be human. And so I was in a psychiatric Facebook group, and one of the docs posted a question and was like, I feel like what I'm about to do is in violation of psychiatric boundaries. And it was something very simple and just very human. And another one of the docs said, always err on the side of being human. So it's similar to what Mr. Mark said, which is like, why do we wear a white coat? We wear a white coat to erect a boundary because I'm in charge and my perspective is more important than your perspective. Now you can wear a white coat for a different reason, but we know that's the reason the system has instituted the white coat. And so you need to be able to talk to your person and change that white coat into a sense of trust. But my medical expertise is as valuable as your personal expertise in yourself. Am I giving my cell phone number to my patients? No. But am I giving my cell phone number to a lot of people? No, right? So like you set boundaries because boundaries are important for autonomy, and boundaries are important for that sense of self-agency that needs to come up as a part of getting in recovery. But if the reason you're setting that boundary is not for safety, and if setting that boundary erects a barrier to a human-to-human interaction, then I think that's the question you can ask yourself in each one of those situations. And if you're not sure, err on the side of being human. There's less fallout that will come from that than the fallout that comes from unintentionally injuring people because of professional boundaries that we've been trained with.
I love that. And I think so much of our training as doctors, but I also think across the kind of care professional spectrum is actually to make us less human towards the people that we're caring for, from the white coat ceremony to, standing up and peering down at someone lying in a bed who's wearing a gown and not in their own clothes, to using language that no one understands, or the types of terms we use to refer to people. So undoing that, I think, is often really hard and takes work. So I guess on that notion, there's a question about undoing, and how do we think about what actually needs to change to allow systems, healthcare systems, recovery systems, treatment systems to embrace the models of care that you guys are so eloquently describing? Everything, no.
I can start, Mr. Mark. I think we have begun to see the beginning of the change that needs to happen. And that is truly caring about the lives and humanity of people who use drugs. It's just beginning. And it sounds sad and accusatory, but I think it's true. I'm willing to receive pushback on this. But that when I was in medical school, I finished 2002. Part of the reason I decided to become a psychiatrist is because as a medical student, I saw what I felt like was the healthcare system did not care if people with mental health and substance use disorders died. And it's the stigma, the moral failing, you did it to yourself, just say no, just make a different decision. And also like the disconnection of substance use disorders. A lot of times when you die, the people who are grieving don't have a voice to put that on the collective consciousness, because as a population, these folks have been invisibilized. And so I think one of the most important things that has come out of the opioid epidemic is faces and voices of recovery, right? Like, I have always loved that movement, but the more we see that it's not those people, like the more that we see that it is us and it is our people, the more just innately biologically we have the empathy to care about their lives. Same thing, Black Lives Matter. Like, the more these people's lives matter to us, whoever these people are, I use kind of that pejorative little bucket term on purpose there, whoever these people, those people are, if we can make their lives truly matter, then we start using data. We start holding the industry to the evidence base. We start looking for the bad players that are exploiting vulnerable people. We start calling out, you have to be ready for treatment, right? Because we know that all of those things lead to people's lives getting worse and or dying, and we don't accept that. So I think lives have to matter, and then structural changes will come after that.
So, Sarah, was you saying, you was asking the question, are there changes in the health center, or do we need to see more changes? Is that what you were saying?
Yeah, what changes do you think need to happen to allow the type of amazing kind of person-centered care you and Dr. Harrison are sharing to actually be the norm instead of the exception?
Just first and foremost is to see people as human beings. We put more emphasis if a dog, something happens to a dog, that you know nothing about that dog, and it comes on TV, and everybody can have compassion for the dog. But here I am in living here in Massachusetts. I know Dr. Zinger may not be familiar with it, but she's familiar with addiction and the impact and effects upon people. So they have a place there, and they have that Mania Cass, which they have kind of pushed those people in a particular area, but they suffering from their addiction. They call it methadone mild. Some people want to call it recovery lane, you know, to paint a different picture. But how do people view them? How are they seen? The stigmatism that's placed upon them and the label that's placed upon them. Which brings me back to this. When you talk about the opioid epidemic, and you talk about disparities in the healthcare center, and when you look at drugs, period, though I was a late bloomer, so to speak, when getting involved with drugs, I do know a little bit about that impact that it had upon the Black and brown community from the 60s and the 70s, and nobody cared because they didn't see it impacting or affecting them. But then the opioid epidemic came out, starting with the Oxycontin that was given to people in 1997. Then it began to explode. It began to affect people in the rural and areas up in West Virginia, Pennsylvania. We see what it has done here in Massachusetts. I remember going with Moore to Capitol Hill in 2010, speaking to the politicians about that. But I was with a particular gentleman who was a board member, Paul Cusick, and I began to learn more about the impact of that drug on his community. He's an upper middle class white man, but I felt his pain. I felt this pain, and the reason I felt this pain because I said, even though he may be white, the politicians at that time didn't even care. And then I started seeing it even in a bigger picture, that there was classism going on, racism going on. And as it grew, people began to change the dialogue around criminality to public health. And it also happened like that in the Department of Correction. It was changed from public health, Department of Public Health to Department of Public Safety. So I think there's a lot going on now, moving towards that. But my hope, my prayer is that they're able to see people as human beings. The indigenous people that I work with, they want to work with themselves and incorporate their particular traditions without not looking at other things that can help them as well. So just allowing people to use that which works for their culture, you know, and then respecting it. And then those of us who may not be of that culture, to just be open-minded to understanding. And that's what I say. I just hope this continues to keep growing and be open-minded.
Yeah, thank you, Mr. Mohammed. And seeing people as human, I think bringing up the humanitarian crisis at Mass and Cass is particularly relevant. There's an article in the Globe today that the title was, "Everyone wants the problem at Mass and Cass to go away, but no one wants the people." Which I thought was so poignant, that everyone just wants to clear the problem, but no one's actually thinking about the humanity and the suffering of the human beings that are enduring that and what they actually need. So I appreciate that framing.
Dr. Wickman, can I piggyback with just Mark and I both went for the humanity first, which is always the answer.
Yeah.
Practically, the system needs to be held accountable.
Absolutely.
So accountability comes through data, right? Like, we're not required to submit data anywhere that is publicly available that says people coming to you are getting better or dying, or aggregate that at a population. We have a concept of what evidence-based treatment is, but the industry is not held to it. A residential treatment program that once they discharge a person, if that person dies 2 weeks later, they have no idea. And so how can that person's death be meaningful to them? Or how can they be held accountable for that? Because their responsibility to that person ends on the day of discharge. And so I would say, practically, what we need is a defined set of outcomes that every single system provider is held to reporting data, and then let there be incentives and penalties, because money moves things faster than humanity, sad but true. And so let there be incentives and penalties based on whether people are getting better or whether people are getting worse and dying from the care that your system is providing, and we would start to see a difference.
Absolutely. And I think that also just shows the disparities in how we think about and approach addiction and people suffering with it than other health conditions, that, hospitals are held accountable. If people get sick within 30 days after they leave the hospital, or if they die 30 days after surgery, we're held accountable financially. And that is important because it drives change. Whereas, family may get fleeced for $60,000, be told to use some sort of loan shark to pay for a residential treatment program that offers nothing that looks like evidence-based care. And when that person dies, there's nothing that happens. That program just keeps on making money.
Yeah.
So I think that's a really good point, Dr. Harrison.
Absolutely.
Mr. Muhammad, I think I interrupted you, so please
No, you
back
did.
away.
I was just agreeing with what Dr. Zinga said. Absolutely.
So we're going to start wrapping up soon, but I think maybe one last question is, concretely or practically, can you give people who are listening some tips for how they could get involved in being a part of change, whether it's in a small way or a big way, if there are advocacy efforts or groups people can join? I think a lot of people have been inspired just listening to you today, and would be great to leave them with a little nugget of some way that they can help move things forward.
Well, one of the things I would say, I'm going to keep it real simple. Go online on the website, look up more. Massachusetts Organization for Addiction Recovery, and they have a host of different things that you can look at and be a part of. More's been around since 1991-92 by a beautiful executive director, Marianne Frangulis. She may be on here, I don't know. But if you want to know anything about advocating for people suffering from addiction and need to be in recovery, More is an excellent agency organization from which you should start from.
I love that. I think very practically, similarly how success in substance use disorders traditionally has been defined as pure abstinence only, which is like pure abstinence only forever for the rest of your life. That's the whole enchilada, which underappreciates the importance of those small successes there. I think if every person from this panel went to one person, whether it's in their personal sphere or their professional sphere, and talked about the importance of compassion and connection, just choose one problematic thing that's within your sphere, personal or professional, and have a conversation about it and compel that person to have a conversation. Those efforts add up. And then of course, more, and talking to your legislation and going back to your program and looking at policies and procedures. But just one person is enough. I do want to react. Cheryl, thank you for putting in the chat box. In reality, most residential staff do learn of a former resident's death and experience profound grief and helplessness. I'm not pointing my comments to the staff. I'm pointing my comments to the system, because I think even though the staff is experiencing profound helplessness and hopelessness and grief, and that has been my experience also, that accountability doesn't roll up to the system to make it do anything differently. And so we're constantly subjecting our people who are serving to that trauma and grief and helplessness at the same time people who are coming through the system are dying. So thank you for shining a light on that, because I think it's an important nuance.
Well, thank you, Dr. Harrison and Mr. Muhammad. I think I can say without a doubt that you left everyone feeling inspired and called to action. That was amazing, and just so appreciate your words and wisdom and sharing your humanity in this panel this morning. So with that, I'm going to pass it back to Julie to introduce the next portion of this morning's event.
That was just absolutely fantastic. There aren't enough words to say thank you for all that you shared, for all of us who are inspired. So thank you, Drs. Wakeman and Harrison, and Mr. Muhammad, for your insight, your expertise. I think we learned so much. There's so much to think about, and your approaches and your experiences and your words of wisdom are so valuable to what's going to happen next. So next, we want to start to foster collaboration and share best practices. And I'd like to welcome Dr. Cheryl Gagne from C4 Innovations, who will lead an interactive discussion on PCC practices. Dr. Gagne's areas of interest and expertise are workforce training, transforming behavioral health programs and systems to promote recovery and person-centered practices, using evidence-based practices in programs, and evaluating recovery-oriented services. Dr. Gagne is a person in recovery from mental illness and addiction and an advocate for others who are in recovery and are striving for their rights to participate in valued roles in communities of their choice. Thank you for joining us today, Cheryl. We're really excited about the next step, and I'm going to turn it over to you.
Yes, hello. Thank you all so much. So this morning, we've really listened and learned, and Drs. Wakeman and Harrison and Mr. Mohammed gave us a lot to think about. But what we're going to do now is really shift our focus and hear from you. And we're going to do this through a facilitated discussion through an app called Mural. And some of you may have used Mural in the past, others not. But this is what you're going to see. This slide here, you'll see there are 4 boxes. Each box is about ask questions or ask you to read a scenario or fill out a survey. And we'll take about 40 minutes in total to have you respond to each question. We'll start with box 1. We'll spend about 10 minutes on that and move through the scenarios. The link, and this is how you access Mural, the link is in the chat box right now. So it's a visitor's link. If you go ahead and click that, you can see a transparent dark screen that will say, "Welcome to Mural, an interactive discussion of PCC practices." So if everyone wants to go ahead and do that. Now, I know some people are really apprehensive about clicking on a link. It might be a computer issue, could just be a personal issue, lack of confidence to navigate a new link. Fear not, we have ways of having you participate in each and every question through the chat box on the Zoom app that you're using. So you can participate even if you do not click on the link. And again, we totally understand, but for those who want to, the link is above, and Lee is telling me lots of folks are joining, so good for you. So when you enter the room, you're going to be summoned to each section. Again, it's a timed section. I don't know how that works, but it does. It's behind the scenes. So you'll get summoned to the next question when it's time. Okay. So let's hear. Tell me if anyone's like in the room and comfy in the room. People are looking. And tell me in the chat. Are people in the room?
I see we have about 49 people in the room already. So I'm going to go ahead and share my screen so that folks who are not can see it as well.
All right, good. Yeah. Thank you very much. And I'm going to stay out of there. Okay, so we're in the first, it is confusing. Thank you, Lisa Marie. So hang on. I agree. It is confusing, but most of you will, if you're in the room, you'll be summoned to this very first question. What do you or your organization do to provide person-centered care? We're really looking for strengths. What are you already doing pretty well as in your organization or you personally? And you're able to respond to this by clicking on a little Post-it note and go ahead and type. Now, there are over in this far right corner on the bottom of the screen, those Zoom settings. So if you're like me, I can't read this. The font is too small. You can zoom to make it larger. Okay, and you can see that people are typing. Keep going. For other folks, I'm going to post the question here in the chat box, and you can go ahead and put your answers here.
Great. I see lots of people adding theirs, and as they finish up, I will make them bigger and we'll be able to see everyone's thoughts. Thank you to everybody who's joining us, and trying this out.
Yeah, I'm starting to see a lot of responses. A simple word like listening as a person-centered practice. And we have to acknowledge that that's probably the most fundamental practice of person-centered care is truly listening. Diligence with language. Other people provided more, detailed program activities, providing harm reduction services, including safe syringe programs. So a whole range from, harm reduction to perhaps recovery support services. Understanding that people need different things at different times in their life with a substance use condition. Sometimes very high intensity supports and others, very few. Okay. How are we doing on time with this one? I know there's a timer built in, so I didn't. Okay.
Michelle, I still think we're still doing okay. And I see a note from Lori. Lori, you can click on anywhere in the white or any of the little spaces, and then the post-it note should come right up.
So yeah, click on a blank one and you'll maybe get a post-it note. Okay. Yeah, I know a couple people may have trouble, and I'm so, okay. Mine didn't come up, but when I clicked on a blank one and started to type, it worked. It's probably very microscopic type and you can't see it, but we'll make these boxes bigger. I think Lee's going through now, trying to increase the font size. And Laurie, there are post-it notes under the question, any of those colored boxes. And a couple people are putting things right in the chat box, so that's great. Feel free to, boast about what you or your organization do to provide person-centered care. Yeah, great. Oh, good. Found the post-it note. I'm not going to lie to you. This was very confusing for me when I tried. It still is, which is. All right. Looks great. So thank you, everybody, for entering the room and giving it a go. All right. All right, let's read a few of these now. And I know they're still small, but you might be able to see, and if you hover around, you can enlarge them. And true informed consent, that's the heart and soul of person-centered shared decision-making, true informed consent. So Lee, have you moved us to question 2? No, yes, okay.
Yep, I opened up question 2.
Okay.
We had our boundaries move just a little bit, that orange line, but I am seeing so much fantastic responses.
Okay, hold it still. I want to read a couple for just before we move on to the vignette. Okay. So one was a real mindfulness practice. Someone talked about every day I remind myself why I do this work, and really getting in touch with that, the humanity, the compassion that you bring to the place, and how often kind of throughout the day we might need to sort of bring ourselves back to that message as providers. There are others, again, true informed consent and shared decision-making as the real heart of person-centered care, providing support, flexible supports. Okay. Providing as much as a person needs. Yeah. How much a person needs. And we do understand that for person with serious chronic health conditions, Sometimes they don't appear into treatment until they do need a lot of intensive needs. And so for a time, there may be high medical costs, high treatment costs, high therapy, housing, but over time, some of those supports or resources change. And that person becomes, can contribute to society. Their value can shine through. Okay, good. Non-judgmental care. Lee, are you going to read any of these? Can you read a couple?
Sure, of course I can. Yeah. I think some important ones about allowing people to be experts on their own lives. That's huge. And also hiring from the community served. People with lived experience bring so much to the organizations that they're able to be a part of. Practicing cultural humility, just like we were talking about in the panel earlier. Providing harm reduction services, safe syringe programs, naloxone distribution, and also Narcan trainings. These are huge person-centered pieces.
A lot of the trainings and resources are very empowering, giving people the tools they need to stay alive and improve their health, right? Clean syringes, naloxone. That's what empowerment is all about. It's not just a state of mind, it's about having the tools and resources you need to, improve your life. Or at least reduce part. Okay, why don't we step over? Anyone in the chat box want to say something? They do groups both for mental health and substance use disorder. Great. All right, we'll go to question 2, please. So has everybody been moved to question 2? Did that happen?
Yep.
Okay.
We're all moved over now.
So this is a vignette, something to think about and reflect on. What are some person-centered responses to this scenario? And this is a 26-year-old person with a history of opioid use disorder who presents for a follow-up visit. They've been on Suboxone for 3 months and are doing well. They express a wish to stop taking the Suboxone, stating they want to be free of all substances. They have concerns because a year ago, they tried to stop Suboxone and it led to a relapse. So what is a person-centered response? You can go ahead again, clicking on those little sticky notes and writing down your ideas about what would a person-centered response. And again, there are multiple correct answers.
Wow, we're getting some really good ones coming through. When people are writing, I can't click on them yet, so I'm going to get to them once folks have completed their thoughts. And yes, feel free to write in the chat. Everybody has a different way. We definitely design for everyone to be able to participate, and this is just a visual tool for us to, look at what everyone has to say. We've got one saying, ask what supports she feels she may need to stay sober. Asking more about reasons behind the decision.
Yep. Yeah, a lot of exploration necessary to help people really. And that was a response people gave in the first question about true informed consent. This is a big decision and helping people walk through that decision making. It sounds like they're making the decision based on one value. I don't want to be using Suboxone anymore. I want to be, I think they put it free of all substances. Well, that's certainly an important thing to that person, but there are other factors they want to consider. And then thinking about the pros and cons, or a real, shared decision-making process of spending time.
Yeah, I see one offering and educating patients about FDA-approved relapse prevention therapy. I think that acknowledging that relapses happen, it's part of the process, is also another one I see here. Also educating about other options available.
We could also, share some of the research data that 3 months of Suboxone is not sufficient to see a dramatic change in abstinence from illicit opioids. So we know that it really requires more than 3 months for most people, the research data. So sharing research data, that person can also bring their expertise to their personal reasons for and what's important to them.
Definitely. Also seeing
Good discussion about what might be different in their lives now as opposed to when they stopped Suboxone in the past. Yep, help the person think through their decision and provide the support they need. Yeah, if you're going to reduce Suboxone or eliminate Suboxone, what else are you going to do to help you manage cravings that may come up, to help you manage, a lot of difficulty. Person might talk about, well, yoga, or, I'm in counseling that's really helpful. So helping the person identify supports, great. Right. And we know, talk about multiple pathways, supports are different for different people. What works for one is not necessarily working for others. Yeah, ask what their preferences are. Thank you, Laura. What helps them with success? What's worked? What hasn't worked in the past? I see a lot of people, although they don't shout it out, they're pretty strengths-based and looking at kind of what the person already has and does. So that's great. Lee, do you want to read out a couple more?
Sure, yeah.
Fonts aren't for boomer eyes.
No, I'm trying to make them larger and not lose them in the rest of it. Asking them their exact concerns. I think that continuing to talk about exploring other supports that can assist along with medical supports. I think that is just huge. Grabbing this other one here to see. My apologies, my eyes are also working extra. I think oh, here we go. Try and create an action plan around the steps of coming off Suboxone safely as possible, and figure out the exact concerns like you were saying.
Yeah. There's some very good trainings these days on person-centered planning, that whole aspect of planning. I've looked at treatment plans throughout, the Commonwealth and other places, both in sort of mental health facilities, halfway houses, residential treatment, and in addiction. And there's a lot in common about all of the, goals and objectives and resources. And I don't believe that people are that much alike, that the same goals, the same resources. In fact, one place I went to, this was funny, who were very proud of their person-centeredness. The first goal was Isaac will submit to random drug testing, by December 2004, something like that. Well, I doubt that was a person-centered goal. Submission to drug testing is not really something we aspire to. So there's still a lot of work on really understanding their person-centered goals. Pay attention to what their body is telling them. Good, these are really good. Describe the standard of care. Thank you. That would require very carefully monitoring and very slow and careful tapering. Yeah, be willing to go slow and reverse, practice patience. Very good. And at any time, if things become super uncomfortable or it feels too risky, a person can then increase. And that happens, that happens commonly. A person really needs to be, as Melissa talked about, in touch with their body and needing to be honest about, cravings and, yeah. Okay, these are great. Are we ready to go to the next
Yeah,
Next
let's
box.
move forward.
Whoosh. So again, person-centered responses to this scenario. So this is another young person, a 23-year-old person experiencing homelessness. They were diagnosed with stimulant and alcohol use disorders. With many high-risk behaviors, including sex work, you would like to see this young person enter treatment right away, but they say they need a week to get their affairs in order. What is a person-centered response? People are busy typing in some responses to the question.
We've got one person saying, what can I do to help you get your affairs in order?
Yep.
See, let them know that you will be there for them when they are ready.
Yeah, I think doing both, staying connected. Let me help you this week as you get your affairs in order. What can I do? How can we stay in touch? We'll set it up for next week.
Ask if there's anything you can help with.
Yeah.
How can I help you with getting your affairs in order?
Yeah, perfect. There's some really
Arranging for a daily check-in, offering help, connecting them to services who may be able to help them get those affairs in order.
great.
Somebody's asking, do you have Narcan for the next week?
Great. Giving people the resources they need to stay safer. Okay.
I think another great one is asking who could help, who maybe they already have the supports but haven't recognized them yet. I love that one from Pablo in the chat, reminding them of all the good things they've accomplished.
Praising the fact that they came in, that this was a very positive step, and staying connected with them. The daily check-in, I really like that. You might need to negotiate down, twice a week check-in, but that's a great offer. Make sure this, that you understand and that you're not disappointed. I think so often with substance use disorders, with trauma, there's often so much shame that people are very sensitive to judgment and, the feeling that I've disappointed someone, I've let people down. And sometimes that can keep people away from seeking help. And so we really want to make the experience as positive and non-judgmental as possible. And I'm so glad, nobody said, okay, let them go and hope they come back, right? That's not person-centered practice. Person-centered does not mean the person, calls all the shots and you disengage. Well, it was his idea. That's what he wanted to do, right? That's not person-centered. Right, every one of you have come up with a great person-centered response and efforts to stay connected, to stay positive, to help them move. And if they disappear, when they come back again, be very happy to see them, welcome them back.
Yeah, I love the I'll be here when you're ready. I think that is just so, compassionate, really, right? That's what it's all about.
Yeah. I think we can think about person-centered care as a very compassionate approach to helping people with substance use disorders or mental illnesses. It's very important to find this person a reliable partner to be for the critical transition time, maybe a recovery coach, good idea, with lots of experience. Recovery coach that might keep the person safe or help them navigate. Okay, these are great. Okay, why don't we go to, has everyone had a chance to, yeah, someone's mentioned in the chat box, I often hear I'm sorry, and that's so sad. That guilt is heavy and not needed. So I think these have been great responses. So this question has to do with, is a question about your organization. You or your organization need to do a better job providing person-centered care. What are some things, either as an organization, as a workforce, as an individual provider, what are some things you need? And you can check all that apply. You can type in where it says other, but this is a survey that we're going to be taking, and okay, I'm just setting up the survey now. And again, for those of you who are not navigating Mural right now, you can go ahead and type your preferences in the chat box. Okay, what you would vote for, some ideas you have for improving your practice of person-centered care or helping your organization deliver person-centered care in a better way. So we're beginning, great. Okay.
Yep, so all you got to do is click one of the cards to add your vote. And then we will be able to see the results once everyone has given their thoughts. Your vote will be anonymous because we want everyone to be as open and honest and authentic as they feel comfortable to in this.
So people are still voting. Lots of good suggestions in the chat box.
I'm going to add a timer just to set us maybe with a minute more for folks
Yep.
to vote. Cheryl,
Yep.
does that sound
Thank
good?
you. Yep, perfect.
Great. All right.
Counting down. And go ahead, chat box will be open for the, chat box will stay open. So go ahead and write your recommendations or ideas for improving your organization or improving your own practice of person-centered care.
Yep, and we'll be grabbing all of the info that folks are sharing in the chat. We'll be adding that to our mural and to our collection of information, and that will be going right to RIZE so that we can get that information to where it needs to go. We want to hear your thoughts.
If we were in person, this would be a time where, we'd have open mic. And so that's really hard to manage with 200 people on Zoom. So I do want to hear from people kind of what this experience was like for you too, but we'll hold off on that for a minute. Okay, so the time is up for voting. If we go ahead and okay. See what the ideas were. It's hard to read.
I can read it for you, no problem.
Thank you. So
yeah, we've got 14 votes for practice shared decision making. That is definitely our top.
Great. And let me say there are some really good tools for learning that. In fact, my organization C4 through the brass tacks contract for SAMHSA made a great toolkit and video demonstrating shared decision making for medications for opioid use disorder. So that's one example. There are a lot of decision-making tools just on the internet. I find they often need to be tailored to your situation, certainly to the individual you're speaking to. You want to, present information in a way that, responds to things that they value, that they think are important, and in a way that it can be understood. Not everyone has medical education, right? So people need to have things translated into, words and images that help. So shared decision-making, or practicing shared decision-making, learning more about shared decision-making, that's a possibility. I think no cost or low cost opportunities exist for that. So that's great. It doesn't require a lot of change in the organization. Many organizations will put in policies as part of kind of how we work with people, that there is a shared decision-making process before any treatment or recovery services decisions are made. So that might be an organizational change, that we now have this policy of shared decision-making. Okay, thank you. Go ahead, Lee. The next two were tied for second.
Yes. These are definitely, going right along with the top votes about asking patients, clients, residents about their experiences. So collecting that kind of feedback, and then also using that information to create person-centered training materials for folks. I think that also goes right into collecting feedback from different stakeholders. So you can ask, patients are a super important stakeholder in their own experience. So I think that goes right into the other top votes that we have.
Yep. And asking people about their experiences and checking in often. Was this comfortable for you? Was this helpful for you? Did this make sense to you? Person-centered training materials. Again, some exist. I found some need to be created to really, really to be tailored to some individuals. But it doesn't need to be high tech and fancy, really just providing information. Collecting feedback from different stakeholders, or doing, ongoing program evaluation. And part of this is building networks, right? We need to have a network of services. Most of us don't work in organizations that can do the whole array of treatment and recovery support services. Certainly we want to be able to link people to things outside the service system as well. And in order to do that, we need to have networks that are happy to collaborate with us, who like to work with the people we work with. And I'm stating it as if that were a simple thing, but it's really worth the effort for an organization to build its network. I think we're only as strong as our networks. So training in person-centered record keeping, I hear that a lot of, electronic medical records or required documentation isn't person-centered, and you have to follow this language that is, very provider-centric, very focused on deficits, problems and deficits. And, so sometimes the record keeping system needs to adapt to really be person-centered. Improvement in coordination and aftercare, that certainly is something that needs to be done. A lot of it it's not just coordination, but being able to find programs, resources for people who are transitioning either out of treatment or out of incarceration, really organizing those resources that people need. Training in person-centered treatment and recovery, absolutely, to be, to again, learn the tools and practice the tools. So I don't know if there were other things that we can see were listed as people clicked others, or did they type in anything?
I do not think we have any others. Most folks If you want to add your other in the chat, that would be fantastic. I also wanted to flag that our other Cheryl in the meeting asked for that toolkit for shared medical decision-making, and Livia has very helpfully put that in the chat, so you can feel free to use that link. But I think that
so the other, I want to shout out another thing, Melissa from the shelter, who talked about, improved aftercare, right? Needing more resources and more time dedicated to transitions out of programs, person-centered care all the way up to the top of the agency, right? Those values permeate. If I'm practicing person-centered care and my CEO practices corporate-centered care or corporate-centered practice, that's a conflict, or that puts me as a provider kind of squeezed in the middle. And so really trying to have person-centered approaches permeate all policies, from our mission statement to our policies and procedures. And Melissa recommends rethinking boundary guidelines. And I think, echoing Dr. Harrison and Ms. Mohammed this morning, that seemed to be kind of a core element of person-centered care, is kind of a genuine, compassionate connection to another person, to the person who is seeking support and services from us. So I'm glad that was highlighted. As much as we can talk about and sometimes complain about organizational structure, and profit driven services, we also have a large control about how we are able to approach the work. Do we come to a place with compassion? And when we can't, that's really a red flag for us to get the support that we need, right? When we find ourselves being less than compassionate or having trouble with a person-centered mindset is kind of a red flag for our own needs, which is beyond the scope of this conference. But my hope is that, you've been able to take some time to learn and practice self-care, because you've been through, providers have been through a really rough 18 months. So we're going to rejoin in the Zoom meeting. We're all coming back together. Okay, very good. So I think I turn it over to you, Julie. Mute.
That was so great. And in addition to thanking Cheryl, I want to thank Bina and Lee. As you can see, without them, this never would have happened, since I can barely manage to keep myself off mute. So thank you all. That was fantastic. Thank you for participating, and for everyone just for your input. And I hope that your ideas are still flowing, because we just have one more piece of the program left, and I'm going to turn it over to Daryl McGraw and Livia Davis from C4, who are going to close out our program with a call to action. So you're not off the hook yet, a little bit more work to do. Daryl and Livia, take it away.
Yep. All right. Y'all already know what it is, man. Man, I don't know, man. Rise, 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 rise. Yo, jeez. Y'all didn't hold any stops. You brought everybody in, superstars in the beginning. Dr. Harrison, Dr. Wakeman, my brother Mark Muhammad. That was crazy. I was like sitting here going, oh man, it's so good. This is so good. So I'm excited for us to be here. Then we did the mural. I mean, like, man, if you in recovery, if you can hear me right now and you in the room, throw a thumbs up. Let us know you still in the building. I want to make sure my screen's not frozen. I want to make sure I'm not here alone. I got Livia here with me. We about to tear this down, about to bring us home. So if you're still in the building, let us know you're here. Shout us out. Let us know that you're still participating. Thumbs up if you're just getting back from mural. So let us know you're in the building. Yep, I like when you say I'm here. I see you, Melissa. Let's go. Livia, how we doing? What we doing? Let's go. Let's chop it up.
We are doing awesome. And what are we doing? We are doing a one-on-one session. So what you will see on the slide and what we're going to ask you to do in the chat box is we're going to ask you, what is one thing you can do to promote person-centered care, from all the strategies, from all the ideas. that we've heard today, or something you're already doing, what's the one thing you can do as a person to keep continuing to promote and implement person-centered care? And what is one thing your organization will do? What is one thing you can work with your organization to do to promote person-centered care? So that's what we're going to ask you to put in the chat box. We're going to read them as we see them. We're going to comment on them, but we really want to think about, what can we take away from here? What's the call to action? What's the one-on-one thing that you can do or continue to do? And we love to hear from you.
Absolutely. While you're thinking about that and you're putting this in this chat, there was so much information from that first panel where Dr. Nzinga talked about the biosocial, cultural, political. Man, it was so much. I was like, wow, we have to really think about that. And when you're thinking about your organization, you're thinking about you personally, then think about the organization. And you made me think, right? When something like George Floyd happens, right? We can't just go through life like it didn't happen. And, you know, you have Black and brown people working within your organization. Are we checking in with them? Are we making sure that those people, as well as the people that we serve, how can we be more culturally competent, making sure we're checking in with each other? I love, Brother Mark, I see you, brother. I love, love, love the human component. We got to bring it back to the human aspect. I love that Dr. Nzinga pointed that out. I mean, in the points that Sarah Wakeman said this morning about the correctional system and the child welfare system. I mean, those numbers, how you just rattled them off, just like, So we've been, man, truly a gift today. I thank the RIZE team for having me and, you know, bringing us here, because this was very, very impactful for those of us that do this work every single day. Those of you that are in the trenches, we're asking you, what can you do? What's the one thing that you could do, man, in person-centered care? I see that chat box is on fire. Let's keep it going.
Yeah, so I see from Sue Coleman, she's saying, I need to start with myself. I need to learn more, think more, reflect more. And I just want to really support that self-reflection, the internal work, taking the moment to really understand, how do I react to the world? What is it that stresses me out? How can I be present? How can I be right here now with this person in front of me, right? And so that is such an important piece, and you know, personal kind of reflection is just critical.
Yes, I love what Melissa says. Melissa says, keep myself in check and support my staff so we can continue to grow and meet folks where they are. The one thing I always do is I always use the we. Yes, this is a we thing, not a me thing. I love it, Melissa. Know us and know them. We are all the same. And you know, and I want to just add to that, Melissa. I love what you're saying. Love it, love it, love it. You know, a lot of times when people come into different communities and they're like, well, how do we help? You know, think about when the first time you go to someone's house, you're a guest, right? So, you know, you don't go in the refrigerator, you don't kick off your shoes and yell at their kids. You go in and you be respectful to their house. Think about people. When you're engaging people, you are a guest in that person's life. You are just meeting them. So act as a guest, act accordingly, act as you've been brought up to act. So you are a guest until, you know, you get to know that person. I love the love this person-centered piece. I think that it got lost along the way over history. We had lost it, and we have to think about how we got here. So now we can reel it back and start to change things for others. It's so much, man. I love the chat box on fire, man. Keep it going. Keep us busy. Keep us busy.
Yeah, I see Lisa saying, provide practical training to frontline staff in my organization at all levels of care on person-centered care and shared decision-making, with examples like the case vignettes. You know, so really what can we do to talk about, what does person-centered care look like in practice? You know, what does it look like in day-to-day interactions? And having vignettes and having real examples and practicing it and talking about it are important tools, right? Because sometimes when we hear concepts like person-centered care, we're like, okay, I think I'm doing that, but what does that actually look like in practice? What does it look like in my daily interactions? And then also, what can my structure, what can my agency do to support that? And one of the other ideas I like in here is from Cheryl. She was saying, you know, very concretely, practically, once I receive the recording from this summit, I'm going to offer to share it with the team, and we're going to discuss it, which is a very practical thing an organization, an agency can commit to. So I love both of those ideas.
Yeah, I love it. I love it. I love, man. This chat box is on fire. We might need a smoke detector or something. The smoke detector is going to go off in a minute. But one of the things that I noticed is that, somebody said culturally competent. And you know what? Sometimes being culturally competent is okay to say, I don't know what I don't know, right? Sometimes you don't know what you don't know. Like, so there's different language. If I say to Mark, or if I'm at Moore and I say, I saw Auntie in the lobby, that doesn't necessarily, like, Mark would know what that means. And different cultures understand different phrases. So sometimes we need to, if you can't engage that person at that level, it's okay to bring in Mark, bring in me, bring in somebody that can talk that language so we can get this work done together. And just, I love the white coat analogy. I never really thought about it till I heard it today. But sometimes that white coat needs to come off and we just need to be who we are as human beings. And if you know what I'm talking about, give me a thumbs up. Let us know what you're talking about. I love the chat box. Strive to understand the full content surrounding each person's circumstances and need. Yes, Adam, let's go.
Thumbs up. I see that as well. I'm wondering too. So one thing that you will do either with as a person or with your organization, we love to bring it right down to anything that you can specifically do. We love to see that action, taking those steps, because sometimes it just is what changes the world, right? Is taking action. So just want to encourage you. I see. Right. There's another response in here. Make sure my organization has an effective and responsive patient comment complaint suggestion process. Yes, right. So how do we collect feedback? How do we make sure that you hear from people? What is their experience of care in your setting, right? And the other thing we've heard from some programs is that they want to make sure that people with lived experience who have experienced accessing care are close to the center of making decisions around policies or reviewing policies. And is there a way for that to be integrated into your system or your agency? How might you do that either in collaboration with people in the community or as part of your own system?
Absolutely. And then we got to be clear. Can we be clear for a second? Can I talk to y'all for a second? Person-centered care is not a spectator sport. This is not one of those where you sit back and relax, and silence is compliance. So if we see things going wrong and we don't intervene, it just continues. So I need everybody to take a pledge that I'm going to step in. I'm going to step out. I'm going to step out. From this point on, I'm going to start stepping out and being more of a person-centered care focused. I don't care what level, if you work at this shelter or if you're the CEO, you need to take that pledge and say, I'm going to step out and step up. Let's go.
I also like that, there Joelle is saying, we want to open a mobile MAT clinic to literally meet people where they are. And, I think we've learned a lot of things during the COVID-19 pandemic too, around what barriers can we reduce or minimize to make sure that care can be available, whether it's telehealth or how do we get out into the communities that have a lot of barriers in order to access care. So really rethinking, how care can be delivered is also a very good strategy to think about how can you expand on your person-centered care efforts. Meet people where they are. Where do they live? Where they congregate? Where do they go right now? What are some non-threatening stakeholders in the community that maybe you can partner with to really reach the community that you want to reach?
Oh, it's so much rich stuff in here, Olivia. I'm seeing continue to reassure and empower my clients. It is about empowerment, walking in. I mean, sometimes when I remember, Mark, when I walked into some of these programs, I was so, powerless and broken. I needed somebody to empower me. Today I walk around, I'm excited. I'm dancing to the beat of my own drum, but it wasn't on my own chord. I had to network. I had to go to places where people believed in me. So if I walk in and the place is not empowering and people don't believe in me, then how am I going to believe in myself? So I definitely need that type of energy walking into an organization. And definitely, I love Sue says start with myself. Absolutely. If you don't believe in the product, that's what I love about C4, working at C4. We believe in the product, they believe in it, I believe in it, we all believe in it. There's no way we can do this work if you don't believe in first yourself and then what we're actually pushing forward. So this is great stuff.
I also want to just highlight, Pablo is talking about providing care options for a variety of cultural, spiritual, and personal preferences. So often, a lot of our healthcare systems, it's a system that has been built on a white dominant culture, right? And so how might you look at the system to say, how can other people from other cultures other than white see themselves represented? How can they see themselves welcomed by that system? And how can we make sure that those cultural, spiritual, and personal preferences are incorporated, considered as part of every interaction? And I know that both Mark Muhammad and Nisenga Harrison touched upon on that earlier as well. I just want to highlight that as just such a critical piece for such a white dominant structure that healthcare is built on.
Absolutely. And building that trust factor. And, we didn't get to talk enough about trauma, but trauma is a big deal for us, definitely coming through those doors. A lot of us are traumatized, and then trust is an issue. So that should be at the leading. That should be leading, understanding the people that you work with, understanding, man, like they always talk about, read the room, understand who you're working with and what their needs are. And if we put trauma first, and we understand that a lot of these people are going to be traumatized when we're working with them, person-centered care is going to automatically identify that, and then we're going to have that get to know you first, because I need you to kind of trust me a little bit so I can help you get to the next level. And I really love where we're going with this. I'm excited that we had an opportunity to do this work today, because hopefully it's like the ripple effect, throwing that rock in the water and it ripples out, and you will go out, and we're going to be changing the game, because somebody needs this work today. Somebody's going to walk into your doors needing this work today.
I think the other thing to look at, and that I've seen a little bit reflected in some of the comments, but also certainly from a fireside chat, is, what systems or what agencies are you part of where you can look to integrate or collaborate with people with lived experience, recovery coaches, peer specialists, family care providers, is because so much of how the peer role connects with people is because by relationship, right? It is the connection that is at the core of so many of the peer roles, is that connection with the person. And so when you integrate some of those roles, they can lead the way in that personal connection that also can be then shared with other provider roles within organizations. They can see it, and maybe there can now be a discussion around those professional boundaries. How can we lessen them so that we can remember the human connection?
Absolutely, man. I don't know. I mean, today I was full, like, usually I'm at the beginning and I'm part of the thing, but I just sat here. It's like, I always say, some days you're the student and some days you're the teacher. And I definitely was a student today. Definitely appreciated a lot of the information that we got, but just really, we have to embrace this person-centered care thing, because, somehow we have slipped away from it. And definitely, a lot of people say that, I go to these programs or I don't go, because I don't feel attached. I don't feel like they can help me, right? But if we're tapping into if we're tapping into that human component, then everybody is reachable, right? Right, Mark? Mark, I see you in the building, man. How you doing, brother?
I'm doing wonderful. Just sitting back, being a student just like yourself.
Man, I appreciate you, brother. Appreciate you.
Likewise.
So I also see from Ellen, she's saying engage residential programs to cultivate true, positive, empowering recovery communities with both staff and residents, and with staff being in the lead of respect and person-centered care. Yeah, residential programs, right? There's a lot of opportunity to look at how can you support, how can you promote, how can you practice person-centered care in residential treatment programs. We often think of accessing care, maybe more episodic, but really looking at residential programs and how they were created, but also how they can be transformative with regards to supporting a person in a critical transition time in their period, could be incredibly powerful. So I love that.
Yeah, I love that too. And Bina's giving us the 1 minute, Livia. We can stay all day. Bina's hitting us with that 1 minute, tapping the clock. But I will say that residential program piece is so significant, because you think about how individuals enter your residential program, right? And we're not responsible for how a person gets there, but man, we should be responsible for how they leave. and you know, the empowering place. It's such a place that you can really tap in and really get that human component going. Person-centered care should always lead at a residential facility. I appreciate RIZE and the team for bringing me through. Man, you know, I got the pink on celebrating breast cancer awareness for my people that are survivors. Shout y'all out, man. Let's go. Let's get it.
All right, and we will turn it back over to Julie. Thank you, Daryl, and thank you all for all your comments. My goodness, this was fantastic.
Absolutely. Thank you all. Thank you. And we are bouncing back to Julie. Julie's in the building somewhere.
I'm here.
Hey.
Well, Daryl and Livia, thank you again for ending our summit on such a great note. It is such a pleasure to have you in our wheelhouse at RIZE. We're so thankful for everything you do with us and for us. And Daryl, I feel like whenever you're around, and same with Livia, I feel like I'm always the student. So thank you for that. And I want to thank all our subject matter experts, contributors, attendees, and a special thank you to the teams at both RIZE and C4 for putting this event on. It took a lot of work to manage the different sort of sections of the program, so thank you. This has been so great, and we're grateful for your time. And just a reminder, after the closing, you're going to be prompted to fill out a survey. Please remember just to take a minute to let us know your thoughts on our session today and guide us in future programming. One of the key values at RIZE, sort of part of it is in our DNA. We always want to make sure that we're collaborating. We never want to duplicate anything. We want to make sure that we're lifting up and bringing forward the work that you all are doing out in the field. So as I said, we're always students and we'd like to hear from you. Don't ever hesitate to reach out to us about anything, but we'd really appreciate if you take the survey today. And with that, we can wrap up, and thank you again and have a great day.